the medical field. And so I really thank you for joining me today, and I hope this is beneficial to you all. I did want to begin with a brief introduction, but first I wanted to read you guys something that I actually wrote recently, and it's similar to just a reflection that I wanted to begin with, and I think it's a good way for us to start. So it goes like this. This moment will pass like everything else. This hardship will pass like many have before. Things appear much larger when they're up close. Sometimes all it takes is stepping back to realize the true scale. I remember when I chose personal growth and goals over love and the heartbreak that it caused. I also remember when I received my first medical school rejection and the devastation it brought. I remember when I chose my husband while he was stuck overseas and couldn't come in time for the birth of our son, and how painful that was. I remember starting medical school with a 6-month-old infant and how scary it felt. I remember feeling like an inadequate intern, trying to juggle so many things all at once. I remember, but those moments pass just like everything else. And when you're faced with an obstacle that feels like a mountain, all you need to do is step back. You'll realize that it's not as massive as it seems. And if it is, then you'll gather up your sense of ambition, your aspiration, you'll move forward and you'll continue on because it'll pass, I promise. So the reason why I wanted to share this with you guys is because if you're here, then you're already on your path to medicine. And that path is not easy. You're gonna be, you're gonna face so many difficulties. You're going to face things that you didn't know you were gonna face. And honestly, if you need to, you're going to continue on, you're gonna persevere, and you're gonna get through it. So let's see if I can get the slide going. All right, so that's my son when we first started medical school. And the picture on the right is when I graduated from medical school. Let's see. So a little bit about me. I am an immigrant. My parents came to the US from Egypt when I was about 5 years old. I grew up north in New York, and I moved to Texas in high school. I went to undergrad at UT Arlington, which is around the Dallas, Fort Worth area. And just like many, the typical med student, I graduated with a bachelor's degree in biology. I then went to medical school at Texas Tech. And honestly, it was during my 4th year that I truly decided to pursue pediatrics. I then went on to do 3 years of pediatric residency at Baylor College of Medicine. And finally, I am now a general pediatrician with a special interest in newborn medicine. I actually now work as a newborn hospitalist in the newborn nursery, and guys, it's literally my dream come true. And many people don't know that as a general pediatrician, you can request to only see newborn babies, but that's what I do, and I love it. So a common question that I get is, why pediatrics? And first of all, there are so many myths that I just wanted to get rid of before we started the presentation. A common myth is, one that people say all the time is, as a pediatrician, all you see are babies with snot running down their noses, or, kids with vomiting, diarrhea, and that is far from the truth. Another common myth is that, it's only women who go into pediatrics. And yes, I am a woman, but I have been trained by wonderful male pediatricians, and I've worked alongside many wonderful male colleagues as well. So again, why pediatrics, right? So honestly, one of the greatest things is when you are in clinic, you get to see a patient during their first newborn visit, and then you get to see that patient along many years until they're in high school. And just being able to see them change and grow and develop is honestly beyond amazing. Another thing, you care for a variety of ages. Like I said, you see a newborn baby, and then maybe the next clinic room, you'll have an adolescent who you're trying to counsel on, STIs and substance abuse. Another reason is that there are so many options for subspecialties. There's adolescent medicine, there's child abuse pediatrics, there's developmental pediatrics, there's pediatric cardiology, there's critical care, emergency medicine, endocrinology, so many different options. Another thing that I really enjoy is the option for doing, if you're an inpatient hospital type of person, then you can have that. If you really enjoy the clinic, then you can have that as well, or you can do both. There is also a focus on advocacy, and of course, kids are cute. All right, so this is a photo during Advocacy Day, which this was taken in Austin, which is the capital of the state of Texas. And this was actually last year. Our aim was to advocate for firearm safety. And just remember that kids do need a legal voice. And so as a pediatrician, you can definitely be that voice for them. And we actually had a medical student there with us as well. All right. So again, I really don't think we need another reason besides the fact that babies are just extremely cute. But if you needed more reasons, we already went over many different ones. In all seriousness, though, pediatrics is a great field, and I always say that babies don't come with an instruction manual, and that's why we need pediatricians. So another question that I frequently get asked, how is a newborn hospitalist, which I am, how is that different from being a neonatologist? So we both deal with babies, but they're actually very different. So a newborn hospitalist, or someone who practices newborn medicine, usually deals with full-term babies that are usually 37 weeks gestation or older. And the NICU will care for the premature babies, or the babies that are born earlier. A newborn hospitalist is also a general pediatrician, so there is no fellowship training. A neonatologist is an ICU doctor, and there are additional years of training after residency. So if newborn medicine, is generally seeing the well babies in the nursery, then why are we important? Why do we have a job? So I think the first most important thing is that we are the first doctors to examine the baby. And that makes our physical exam super, super important, because you can pick up on so many different crucial findings. So usually you need to be really thorough, you need to be detail oriented, and you need to be able to kind of pick up subtle cues, because babies can't talk, they can't tell you where things are wrong or where things are hurting. And so you need to be always on high alert to be able to pick up on, what's normal and what's abnormal. And a huge part of pediatrics in general is being able to distinguish between the two, between, this is a normal finding and this is not a normal finding. And it can be difficult to kind of distinguish the two. And I'll show you some examples of that later on. Another thing that we do is we realize, okay, this is a sick baby, and this is a baby that needs to go to the NICU. This baby requires higher level of care. Again, we said there can be really, really subtle signs, and so we need to be able to pick on those things. So for example, a baby with sepsis may not have, a true fever, but they can have just subtle temperature instability or changes. And that alone can be a trigger or can be a sign that says, okay, something is going on. And even when babies aren't feeding well, that's a common issue. It could be due to many things, but even something as, scary as sepsis can present as a baby who's just not feeding well. Let's see what else. So we do routine newborn care, and we'll talk a lot about that as well. Some newborn hospitalists will go to the delivery room and attend the deliveries. And so, you need to be skilled at neonatal resuscitation, which is extremely different from adult, CPR and all of that. Another thing we do, like many general pediatricians, we talk a lot about anticipatory guidance. There are lots of first-time moms that, again, babies don't come with a handbook. There's no handbook that, you give to parents later when they leave, and you need to be able to talk to them about safety. And they may not be able to see a pediatrician right away. And so you really need to be able to educate those moms about what to do and things to watch out for, things that, can happen that they need to bring baby back. Let's see. And then we do procedures as well. We do circumcisions, lumbar punctures. And so those could be a lot of fun as well. All right. And you guys, my goal today is going to be mainly to open your eyes to a field that you may not have heard of before. I know pediatrics in general is one that we are all mostly familiar about, but I wanted to specifically talk about newborn medicine and hopefully show you some common issues we deal with starting from head to toe. All right, so we go into the room, baby's already born. And a couple of things that we need to do. We assign, of course, the gender. We assign an APGAR score, and we'll talk about that as well. And then we take a look at, baby's gestation, or how many weeks from the first day of mom's last menstrual period. So that determines whether baby is preterm, so that's anyone that's less than 37 weeks, their term if they're 37 and up, and their post-term if they're 42 weeks or more. All right, so we've assigned gender. We know that baby is term. We weigh baby, right? And that's, that's the fun part where parents, bring their phones, take pictures of baby up on the scale. But the reason why it's really important is that we can classify babies based on their gestational age. Again, so on the bottom of that middle photo, you see the weeks gestation. And then you also take a look at their weight. And based on those two things, you can classify whether a baby is large for gestational age. So that's a baby that's over the 90th percentile. Or if this is a baby that's small for gestational age or less than the 10th percentile. And those things are really important to classify because that can tell you that, baby may experience hypoglycemia or low blood sugars, and you can anticipate the types of problems that may occur. All right, it's lagging here a bit. Can you guys see the next screen, the slide?
Oh, not yet.
Okay. Oops. All right, here we go. All right, so now that we've, classified those things, we're gonna start examining baby, like I said, from head to toe. So the first thing, we're gonna take a look at the head. And the first thing that you usually will notice is the shape of baby's head. Usually babies will have some type of molding because, as you can imagine, when baby is passing through the birth canal, the shape of their head will change to fit in for baby to come out. And so most of the time what you'll see is what we call molding, or they kind of look like they have a cone-shaped head. Another thing is that whenever they do have molding and you palpate or you feel their skull, you'll see that their sutures are overriding, meaning that they're overlapping. And if mom needed forceps or needed a vacuum assisted delivery, you can actually see bruising or cuts on the scalp as well. Guys, if you hear my daughter, she's in another room, but I promise I told her she would get a cookie if she stayed there. All right, so the next thing we're gonna do is we're gonna check the fontanelles. So that's the baby's soft spot. And so babies will have two soft spots. You have the anterior fontanelle and you have the posterior fontanelle as well. What are we checking? So when we palpate the head, what are we checking? So the first thing is that you're gonna see, is this fontanelle a normal size? If it's large, that could be associated with hypothyroidism or low thyroid. If you see that the fontanelle is bulging, that can be a sign of increased intracranial pressure, and that could be worrisome. It could be a sign of meningitis or something called hydrocephalus, where there is accumulation of that CSF, and so it causes that fontanelle or that soft spot to bulge. The opposite of that, so if the fontanelle is sunken, then we're worried that baby is dehydrated. Another thing is that you're gonna palpate to make sure that babies have the sutures. And if you see that these sutures have closed when they should, be open at that age, and you worry about something called craniosynostosis. So when you examine baby's head, you're looking for many, many different things. Another thing that you'll check for is swelling. Again, it's very common because when they pass through the birth canal, it's very common to see some type of swelling. But there are different types of swelling. And again, we go back to normal versus abnormal and things that you need to watch out for. So one of them is called caput, and that is just diffuse swelling of the soft tissue around the scalp, and usually will occur right after birth, and it doesn't increase, right? It doesn't get bigger. And again, that's just secondary to that pressure against the vaginal wall. So what you can do is if you kind of touch it and press on it, what you'll see happen is that it'll cause what we call pitting edema. So when you press your finger really firmly on and you continue pressing and then you let go, you'll kind of see it stuck there. It's pitting. You see like an indentation. So if you compare that with something else called a cephalohematoma, that's actually due to bleeding. And because of the location, that can be, oops, hold on, my daughter came in. Hi, Hannah. You wanna go watch until mommy's done? Okay. All right, so the cephalohematoma is bleeding, like we said, and the reason why we have to be a little bit more vigilant with that is that because there is bleeding, there's red blood cells, and if the red blood cells break down, then they can release bilirubin, and that can cause jaundice, and we'll talk a little bit about that in the next slides as well. But a cephalohematoma is actually really common. Yes, Hannah. Okay, you can go. My son actually had this when he was first born, and you guys, they look like an alien with like a separate head on top of their head. So it can look really frightening for parents, but usually they will improve and it'll resolve. Usually it does take time, a couple of weeks to maybe months, but it does resolve and it does get better. All right, and another scary one, super scary one, is what we call a subgaleal hematoma. And the reason why it's scary is because, again, it's location. So this one can cross a very large space, and we worry about that because it can just continuously bleed. And of course, that would be really scary, and it could be life-threatening. So how do we distinguish? How do we distinguish this? We need to be able to do that based on our physical exam. So again, we talked about caput. That one you'll press, you'll see that pitting edema. With a cephalohematoma, usually that one will not cross the suture line. So it'll just be in one specific place and the swelling doesn't cross the sutures. A subgaleal hematoma, which is the scariest one, that one you can actually see because of the bleeding in the large space, it can protrude the ear, so the ear can come out slightly. It can even extend down to the neck. So you'll be able to see those things, and that'll be a clue as to, oh my goodness, something is going on. All right. Another thing that we check, of course, when we're checking the head is, checking the head size. Microcephaly means small head. Macrocephaly is a large head. And again, the reason why we worry about that is because if this is a large head, that could be due to hydrocephalus, or again, that buildup of CSF fluid. And so that could be potentially worrisome. And then if it's a small head, then you're worried about, certain infectious disease. If you guys remember, Zika virus caused that. And other genetic diseases can do that as well. All right, so then we're gonna take a look at the face, right? That's the one that's staring right at you. The first thing you're gonna do is you're gonna just note the general shape of the face. You're gonna take a look at the nose, the mouth, the chin. The picture that you see there is what we call micrognathia, and that just means that there's a small lower jaw. That can be problematic with feeding. As you can imagine, trying to latch on and coordinate that could be really difficult for these babies. And it could be associated with genetic syndromes. And so you need to be able to examine baby really well and see if there are other physical signs of that there may be a genetic syndrome associated with that. All right, more things. We're gonna take a look at the ears. Now, you probably didn't really take a close look at a baby's ear before, but they're actually super, super important because that can also tell us a lot about potential things that are going on. First, you're gonna take a look at the general shape. You're gonna look at their position. I didn't know this, you guys, but there is a way to know whether the eye alignment is, I guess, normal. And as you can see from the picture there, you just kind of draw a line you kind of draw like an imaginary horizontal line from that outer canthi of the eye. And then you draw that all the way across the face and kind of all the way to the end where you can palpate that occipital protuberance. If it is below that line, that is what we call a low set ear. Usually you want it to just be perpendicular. So if it's low set, what does that tell us? Again, it could be associated with many, many genetic syndromes. And then you can even have what we call microtia, or small ears. And that is also really important because it could be associated with other abnormalities in the ear, with hearing loss. And so if we see a very small ear, then what we do is call ENT and make sure we have a good, thorough ENT evaluation and a hearing evaluation as well. And whenever you have significant ear anomalies, most of them are associated with renal or kidney anomalies as well. And so for some of these ear anomalies, we will get a renal ultrasound just to make sure that the kidneys are okay. All right, more things, more physical exam findings. Eyes. Eyes are also super important. So when you see a baby, most babies that you see or newborns that you see will have kind of these eyelids that are super edematous, and they can barely open their eyes, and that usually goes away after the first 1 or 2 days. When you are able to open their eyes, then you're going to check the sclera. So that's the white part of the eye. Sometimes on that picture on the bottom there, you can have a subconjunctival hemorrhage. And what you want to see is, if you see bleeding, you want to make sure it's only to that sclera. It doesn't go past it. And that can be just a normal finding due to the trauma of passing through the birth canal. Another thing we do is we're going to check the pupil size, their eye movements. We're going to check the red reflex with an ophthalmoscope. And that's super important too, because you can pick up on lots and lots of important things. So this is a picture of a baby that has cataracts due to rubella. And again, you will need an ophthalmoscope and take a look to make sure that babies have a normal, this is abnormal. So you want to make sure the babies have a normal red reflex. If it's opaque, if it's white, that's abnormal. And you'll need ophthalmology to come and examine the baby as well. This is really interesting. I don't know if you guys know this, but the picture on the top, this is a baby or a child with Down syndrome. And if you take a look at his eyes, you'll see what we call brush field spots. And they kind of look like salt and pepper speckling. And that is, you can see that in the iris, which is that colored part of the eye. It could be normal, but it could also be associated with Down syndrome. And so again, your physical exam is really important, because if you see other physical exam findings that are associated with Down syndrome, then you need to kind of, get further testing and work the baby up. Another thing that we do to most babies in the nursery is we give babies that eye ointment. It's erythromycin, which is an antibiotic, and it's used to prevent gonococcals. So that's gonorrhea that may cause conjunctivitis or infection in the eye, and it could eventually lead to blindness later on. And so moms can even be asymptomatic, and so we just give it to all babies to prevent such a devastating complication later on. All right, the next thing is, so we've checked the eyes, we're gonna go to the nose. This is really interesting. So sometimes what you'll have is a baby who, when they're calm, they're blue and they're not breathing, like you're like, oh my goodness, what is going on? And as soon as you aggravate them or they start crying, then they're breathing well and they're pink. And you're like, what is going on? So this can be due to something called nasal choanae. And that's a fancy term meaning that there is something wrong with the opening that connects the nose to the oropharynx, or the back of the throat. And to diagnose it, it's really fun. All you have to do is take a catheter or a nasogastric tube and you try to place it. If you're not able to, then you know that there is an obstruction there. And so you can easily diagnose that just by trying to pass a tube. Another thing that you need to take into consideration is, again, when you're looking at the nose, if all of a sudden you see a baby with just diffuse, snuffles, they're sniffling, they have a runny nose, that's, that needs to be worked up, because that could be a sign of congenital syphilis. If baby is just sneezing nonstop, that can be due to withdrawal from mom using drugs and while she is pregnant. Specifically, opioids can do that. So again, they're very subtle signs, but you need to be aware of them so that they can alert you that things may be going on. All right, we've taken a look at the eyes, the nose. We're going to take a look at the mouth. Lots of interesting things that you can find in the mouth. One of which, the first thing that is easy to pick up is if baby has a cleft lip, right? You see that, you know what it is. Something that may be subtle is if baby has a cleft palate, and you won't be able to see that unless you open their mouth and you use a gloved finger and palpate the roof of the mouth. Another thing that you can check while you have a gloved finger is that, does baby have a good suck reflex? Because that will help baby feed. Um, Another thing that you can see is the uvula. We have one uvula in the back of our throat. If you see what we call a bifid uvula, meaning it kind of has two halves in there, you're like, something is going on, and it could be associated with a cleft. But this is a submucosal cleft, so you won't see it. But if you take your finger and you palpate, then you can possibly see that there is a cleft on the roof of the baby's mouth. Another thing that parents kind of freak out, I don't have a picture of it here, but babies can be born with teeth. And it looks super weird. It looks really strange, but it does happen. And usually it's best to just leave that tooth alone if it's not causing trouble. But if you go in there and you see that this tooth is, it moves really easily, that could be a problem, because if it does come out, baby can aspirate, so it can go into the lungs, so that you do want to remove. Or if mom's like, oh my God, I cannot breastfeed this baby, there is a lot of pain, I can't do this. Of course, we want to promote breastfeeding, and so that would be an indication to remove and extract the tooth. Or if you see that it's just causing a lot of irritation, or if it's causing injury to the baby's tongue, then might as well just remove it. So that, I know it's weird, but if you see it, make sure that it doesn't move and it's not causing problems. Another thing that parents will usually ask me about is they take a look and they see these like little white spots. They kind of look like teeth, but they're not. They're called Epstein pearls. And what they are, it's benign, it's normal. It's just epithelial tissue that just becomes trapped there. And so it kind of looks like a white tooth, but or a pearl. Something that looks very close to that is called a Bones nodule. Again, they're just white bumps on the gums of baby's mouth. They look like the teeth, but they are not. All right. Now we're going to go down. So we're done with the face. We're going to go down to the chest. Again, when you're taking a look at the chest, the first thing you're going to do is just observe. A lot of our exam is just honestly observation, and parents will watch us standing there watching their baby. And what I do is usually I'll talk through it with the parents. I'll say, all right, I'm watching their chest rise right now. I am listening to their breath sounds right now, and I'll walk them through what I'm doing so that they know that, these are the things that I'm watching out for. Here are the things that I'm trying to listen to. So the chest is important because we can see signs of increased work of breathing. What does that mean? Literally, that baby's working too hard to breathe, which is abnormal. So things that can tell us that baby's working hard and is having trouble breathing is if you see them breathing too fast. So if baby seems like, he's panting, or if you want to be technical, if the respiratory rate is over 60 breaths per minute, you're like, oh no, why is baby breathing so fast? If you look back at the nose and you see it flaring, you're like, oh my goodness, why is baby trying so hard to take air in? Sometimes babies will make like a grunting noise. That also tells you something is going on. And then if you take a look at the chest and you see their muscles being sunken in between the ribs while they're breathing, that tells you that baby is working too hard, and that there is something going on. So there are lots of reasons why babies can have trouble breathing. We're not going to go through every single one of them, but I did want to point out the main ones. So the first one is what we call RDS, or respiratory distress syndrome. And that's usually seen in the preemies, in the babies that are born early. And what that is they don't have surfactant. Surfactant is necessary for the alveoli to expand. If you don't have that, then they won't be able to expand, you won't be able to take a lot of air in, and you won't have a good air exchange. So when a baby's born early, they don't have time to make enough surfactant, and that's why they're at the highest risk. So usually we don't see this in the normal well baby nursery, but you can sometimes see that. Another thing that's really interesting is something called meconium aspiration syndrome. So meconium just stands for the baby's initial stool. And sometimes if the baby, for some reason, is stressed inside the uterus or during the delivery, during labor, then they'll poop meconium while they're still inside. And that gets tricky because, as you can imagine, that stool, that meconium, is really, really sticky. It's like the stickiest, grossest thing that you've ever seen. And if baby aspirates that, or some of that meconium goes into the lungs, that makes the lungs really, really angry. They release all kinds of inflammatory factors. And because it's so sticky, it causes obstruction, air trapping, and those little alveoli in the lungs, they can actually just rupture, they collapse. And so it is not a good sign at all. And so you can actually find out by asking someone who was at the delivery, was the amniotic fluid meconium stained? Did baby pass stool as they were being delivered? You can sometimes actually see meconium underneath their nails. And so that can be an indication that baby did pass stool early on. And then chest x-ray can also help you as well. I know that it's sometimes really difficult to distinguish them, but you can actually do that if you take a look at many of them. Another reason why babies can have trouble breathing is something called TTN, or Transient Tachypnea of the newborn. So the name does help you out because it's transient. That means it will get better. Tachypnea meaning the baby's breathing too fast. And of course, this happens in the newborn. So this happens when those small alveoli in the lungs didn't reabsorb the amniotic fluid. So they didn't get rid of the amniotic fluid that was there when baby was in the uterus. Risk factors for that is if mom didn't really have active labor, she had maybe a scheduled C-section. So again, those normal things that happen during labor that will let the lungs know, hey, we're about to go into labor, baby's about to be born, let's reabsorb that fluid. All of that doesn't happen. And so those babies are at the highest risk for a TTN. Again, it's usually a clinical diagnosis. And then when you do take a look at x-rays, you'll see flat diaphragms, you'll see a really hyper expanded or a huge lung, and then you can see fluid in the fissures. So kind of where that arrow is pointing, those two arrows are pointing, that shows you that, hey, there's fluid there. And that could be an indication that we're dealing with TTN. Most of these babies will get better. You can give them some oxygen, support them, and they'll resolve by about 48, 72 hours, and they do get better. Another thing we have to watch out for is pneumonia. So neonates can have pneumonia. And we call that early onset pneumonia. Risk factors for pneumonia, again, information that you can gather from your history is, mom will say she had prolonged labor, she had her rupture of membranes, or meaning that she's been leaking for quite some time. It's been over 18 hours where she's just been leaking amniotic fluid. And the reason why that's important is because the longer that's going on, there is more risk of infection. And if mom does get an infection, we call that maternal chorioamnionitis. And so if the OB tells you, oh, we just treated mom for chorio, and you see baby now having trouble breathing, spiking a fever, all of those things could be an indication that baby has an infection or pneumonia. And so we'll treat babies with ampicillin and gentamicin, which are two antibiotics that we usually use. And most of the time, the bug that causes this is called group B strep. And so that's also important to know. Mom, were you GBS positive? Were you treated adequately? Because moms who are GBS positive need to get antibiotics during labor to prevent things like this. All right, another thing. If baby's not breathing well, yes, it could be a lung issue, but it can also be a heart issue. And the heart and lungs are closely related. And so again, you need to expand your differential. You need to think, oh my goodness, maybe it's the heart. Things that we can do in the nursery that is of super great value is using the pulse ox. It's, really easy. It's not invasive. All you do is put a pulse ox on the baby's right hand, and you put another pulse ox on the baby's foot. And you take a look at your oxygen level. So what is this doing? It helps us to screen for something called critical congenital heart disease. And we're not going to go over this, but as you can see from the screen, there are lots of congenital heart diseases that can have devastating effects and can actually lead to death. And so we're able to pick up those heart diseases just by doing this screening pulse ox. And a pulse ox that is what we call positive is if it's less than 90% on either the hand or the foot. That tells us why is the O2 level so low. Or if there is more than 3% difference between that pulse ox in the right hand and the foot. If there's more than 3% difference, then we think, oh no, there may be a heart defect that relies on the PDA or the ductus arteriosus. And so there may be an underlying congenital heart disease. And so once we rule out any respiratory issues, then what we would do is obtain an echo or an ultrasound of the heart and consult cardiology. All right, so that's all that I'm going to talk about in the heart. What about, we're going to go down, we're going to take a look at baby's belly, the abdomen. We're going to check to make sure it's soft. We can hear bell sounds. And most important thing we ask about is, did baby pass stool? And why is that really important? So usually most babies are going to pass at least one stool in that first 24 hours. But if 48 hours have passed and baby still hasn't stooled, then we need to think about what is going on. Again, we need to look through a differential. Things we need to consider, something called small left colon. And again, the name is really helpful because that descending colon is small and it has dysmotility. It's not working as it should. And so if it's not able to have that normal motility of the gut, then stool will not be expelled. That is associated with maternal gestational diabetes. So if mom had diabetes while she was pregnant, baby, is at risk for something called small left colon. There's also something called Hirschsprung disease, and that just means that there is an absence of nerve cells in the colon. So again, things aren't moving as they normally would, and that would cause baby not to have poop or stool. Another thing is meconium ileus, and this is associated with cystic fibrosis. And again, just that stool is super sticky and it's not able to pass through. And again, those would be things that we would have to work up if baby hasn't pooped in 48 hours. All right, next we're going down. I apologize, these are graphic, but they're babies, so it's fine. So if we have a baby boy, we're gonna examine the GU area. So again, we're going to take a look at the scrotum first. We're going to take a look at the color, and that just differs between different ethnic groups, so it's totally fine. There are times where I would be worried is if I see that the two sides of the scrotum, the color is different, or if one side looks more bluish, that would be an indication that, oh no, the testy may have a problem, and so I would need to take a look at that a little bit more. So something that I didn't know before med school is that the urethral opening is usually at the tip of the penis, but it could be in different locations. So it's called hypospadias when there's an abnormal opening that can be actually anywhere from just below the end of the penis all the way to the scrotum. It could be anywhere along that line. And then it's called epispadias when it's located on that dorsal surface. So those two things are abnormal, okay? It's not normal. And I would not perform a circumcision on those babies because, believe it or not, if they need to correct that, then they actually use the foreskin, and they will use that foreskin to correct it. And so I will not chop off the foreskin if I see something like this. Another thing that we can see is something called a hydrocele. And as you can see from the photo, that is just when the scrotum is fluid filled. But that is totally normal, okay? Many boys will have that. We need to distinguish it from the scary things, from the abnormal things, which would be, for example, if you have a loop of bowel in there, that would be a hernia, and that would be abnormal. And so one thing that you can do is, if you see that next picture, they have a source of light and they are transilluminating. And if it transilluminates, if you can see that, that means it's fluid. If you don't see that transillumination, that means there's probably a solid thing there, which could be a bowel. And so that you would worry about a hernia. And you can also palpate it if you feel, there is a testicle, in there and you can feel the fluid, then that's probably a hydrocele. If you can feel a loop of bowel, then that's what it is. And then of course, if you take a look and you are just not sure, what we call ambiguous genitalia, then this is a medical emergency, because these babies can also have electrolyte abnormalities. So their sodium can be off, their potassium can be off, and that can be life-threatening. And so those babies I would send to the NICU right away. I don't have a picture here, but for females, again, you're gonna take a look. You're gonna see sometimes baby girls will have discharge from their vagina, and that's very common. It's often just clear, thick, kind of white. Sometimes you do see it blood tinged, and again, that is normal, usually lasts a few days. And the reason why some girls will have that is because mom's estrogen now, once baby is out, they're not exposed to mom's estrogen, and so baby gets what we call like a withdrawal bleeding. So it's normal for a couple of days, and then it should stop. All right, we're gonna take a look at baby's extremities. So this is something that I would do. I would count each finger and toe, and that is really important, believe it or not. So what you can do is, if you see in that left picture there, this is a preaxial polydactyly, which means that there is just an extra digit, but on the thumb side. And then on that last picture, it's the opposite. So this is a preaxial, which is, sorry, I mixed them up. Preaxial is the thumb, postaxial is that little pinky. So if it's near there, then it's called postaxial. One thing that we would need to make sure of is there bone fragment? Because if there is bone, then you want to send them to surgery. You don't want to remove something that has bone. Usually, sometimes there are some pediatricians, if they get an x-ray, they have made sure that there's no bone fragment. They'll actually put a little suture there and kind of tie it off, and then it'll just come off. But again, you need to be sure that there's no bone fragment there. Usually though, I will just send these babies to a hand specialist or a surgeon, and they can do that later on when baby's a little bit bigger. Sometimes there is a family history, so you can ask mom or dad, you know, does someone in the family have this? And you would be surprised. Right, we are gonna run out of time, so I'm gonna go quickly. You're gonna flip baby over, you're gonna check the back. One thing that you can see, which is again really bizarre, is that there could be a sacral skin tag, which you can see in the photo. The thing with this though is that you want to make sure that the baby's spine is normal, and so I would usually get an ultrasound to make sure again that the spine is okay. Let's see, neuro. This is actually really interesting. So as you are probably aware, whenever a baby is being delivered, lots of injuries can happen. And one of those injuries can cause Erb's palsy. And what that is basically an injury to one of the cervical nerves. And it's actually really common, believe it or not. And what happens is when you have an injury to those nerves, then normally a baby is kind of in a frog-like position, their hands are up. But now you'll see that one of the baby's arms is adducted, so it's close to the body, it's down, and it's internally rotated. So it's what we call a waiter's tip, kind of like if a person was, you know, trying to get a tip from somebody, they have their hand to the back. But this will get better. You do need to make sure that baby and mom know that they need physical therapy, and the pediatrician needs to be aware of this too so that they can monitor it later on as well. All right, other things that we do, we make sure all babies get a hearing screen before going home. We also make sure that babies get a newborn screen. And newborn screen, we usually know that as the PKU test. So that's the one where they poke the heel of the foot and they draw blood and they squeeze that and send it off. So different states will have different recommendations, but usually we will do that when baby is about 24 hours old. And that tests for many, many important conditions to be aware of. We test for cystic fibrosis. They test for lots of endocrine issues like hypothyroid, and lots of metabolic disorders as well. And those are really important to know ahead of time because they can, you know, save a baby later on. We also give baby their first Hep B vaccine. We give them the vitamin K shot. And that's actually also super important. Some parents are starting to refuse that. Okay, baby, give me a minute. The reason why vitamin K is important is, again, it's important for blood clotting. Babies will have low levels of vitamin K, and it takes them a while before their body is able to generate that. And so they are at risk for bleeding in those first couple of days of birth. And so to prevent what we call a hemorrhagic disease of the newborn, we will give babies a vitamin K injection, and it lasts them until their body is able to produce their own. Another thing that we do is check bilirubin, and really briefly what that is if when our red blood cells or baby's blood cells break down, they release something called unconjugated bilirubin. And what that does, yes, Mama. You want to eat? Okay. So that bilirubin will go to the liver. It'll be processed into a water-soluble form. We call that conjugated bilirubin, and then it goes to the GI tract, and it goes out of the baby's body through stool. But babies have more red blood cells. Their red blood cells have a shorter lifespan, so they're breaking down more often. And baby's enzyme in the liver that helps conjugate it is, you know, still premature. They're still babies. It's not working as effectively. And so all of those things will cause high levels of bilirubin. And what we do is once we check baby's bilirubin, we plot it, you know, based on, again, the age, how many hours of life baby is at, and the total serum bilirubin level. And based on this nomogram from the American Academy of Pediatrics, we can tell whether baby is at high risk, medium risk, or low risk. And what is the risk? What are we worried about? So bilirubin is lipid soluble. It'll cross through the blood-brain barrier, and it can deposit in the brain, and that can cause lots of neurologic abnormalities. And so we don't want that. We want to prevent that. And so the treatment for that is, of course, phototherapy. And so that is why we screen all babies at 24 hours of life. And if you see a baby that's jaundiced or looks yellow before 24 hours, that is pathological. You need to work that up and find out why. But again, that is something that we check on all babies. All right, you guys, I know I really zoomed literally past a lot of those slides. The time just went by really quickly, but I'm available to answer your questions as well.
Thank you so much for this talk. I don't know if you can see the chat, but people are saying that they absolutely loved your session and that you should definitely consider teaching, because people would love to have you as a teacher.
Oh my gosh, you guys are so sweet.
And we know that the time has kind of run out. You're obviously more than free. We don't have to do any questions since the hour is up, but if you have time for just a couple of questions, or we can have you back for a Q&A. People would love to hear you talk some more. You were amazing.
Oh my gosh, you guys
a lot
are
of
really
requests
sweet.
for you to come back.
Oh, I'm really sorry that my daughter was like in and out, and I feel like I rushed through everything, but I really, really appreciate you guys so much.
I guess, you know, we can maybe do another Q&A session. I know your daughter's waiting for her cookie. She's been pretty good.
I don't know if you guys can see her, but she just brought me a tomato.
You have a lot of, I think, pediatric converts here. We learned so much from your session. This was really informative.
Also, your daughter has sold the show. She's also a star.
She literally brought me like just a fresh tomato that she just bit into.
Yeah, I think if you open the chat, you can just see the praise that's being thrown your way.
You guys are so amazing. Thank you for the opportunity.